Question 1. A 68-year-old female patient presents to your clinic with a history of osteoarthritis and asks about the most appropriate pharmacological therapy for her condition. After a thorough assessment, you determine that she has stage 2 osteoarthritis of the knee with moderate pain and limited range of motion. Which of the following treatment options is most appropriate for this patient's condition? A. High-dose corticosteroid injection. B. Non-steroidal anti-inflammatory drugs, NSAIDs. C. Opioids for pain management. D. Antidepressants. Answer: B. Non-steroidal anti-inflammatory drugs, NSAIDs. Explanation: osteoarthritis (OA) is a degenerative joint disease that is often managed initially with conservative treatments such as non-steroidal anti-inflammatory drugs, NSAIDs, for pain relief and inflammation control. NSAIDs such as ibuprofen or naproxen are typically used in the early stages to reduce symptoms and improve joint function. Corticosteroid injections may be considered for more severe cases or flare-ups, but they are not first-line therapy for stage 2 OA. Opioids should be avoided in this case due to their risk of dependence and adverse effects. Antidepressants, while useful in chronic pain management, are generally not a primary treatment for OA unless there are underlying psychiatric issues like depression or anxiety. Question 2. A 54-year-old male patient with a history of smoking and hypertension presents to your clinic with complaints of shortness of breath, fatigue, and a productive cough for the past few weeks. Upon examination, you note wheezing and crackles in both lungs, and a chest X-ray reveals signs of chronic obstructive pulmonary disease (COPD). Given his risk factors and presentation, which of the following is the most appropriate next step in management? This patient: A. Initiate a regimen of inhaled corticosteroids. B. Refer for lung transplant evaluation. C. Prescribe antibiotics and steroids for acute exacerbation. D. Perform a spirometry test to confirm diagnosis and assess severity. Answer: D. Perform a spirometry test to confirm diagnosis and assess severity. Explanation: COPD is a progressive lung disease often caused by smoking. In order to confirm the diagnosis and assess the severity of COPD, spirometry is the gold standard diagnostic test. It measures airflow limitation and the degree of obstructive disease, helping guide treatment decisions. While inhaled corticosteroids can be part of long-term management, they are used when patients have a confirmed diagnosis and require additional therapy beyond bronchodilators. A lung transplant is generally considered in advanced COPD with severe impairment, not in early or moderate cases. Antibiotics and steroids may be used for acute exacerbations, but the first step is confirming the diagnosis with spirometry. Question 3, scenario-based. Mr. Turner is a 72-year-old male who has been managing his type 2 diabetes for the past 10 years. He has recently experienced frequent episodes of hypoglycemia, particularly in the early mornings. His blood glucose levels have been erratic, with some readings dropping below 15 mg/dL during the night. He reports a recent change in his medication regimen where his healthcare provider increased insulin dosage. What is the most appropriate action to take in managing Mr. Turner's hypoglycemia? A. Increases insulin dosage to manage hypoglycemia. B. Educate him on monitoring blood glucose levels during the night and adjust insulin doses accordingly. C. Prescribe oral corticosteroids to prevent further hypoglycemic episodes. D. Refer him for a continuous glucose monitoring system (CDMS) immediately. Answer: B. Educate him on monitoring blood glucose levels during the night and adjust insulin doses accordingly. Explanation: Mr. Turner is experiencing frequent hypoglycemic episodes likely related to an increased insulin dose. The most appropriate response is to educate him on monitoring his blood glucose levels at night, as nighttime hypoglycemia can be a common issue in diabetic patients on insulin therapy. His insulin doses may be necessary to avoid hypoglycemia, especially in the early mornings when blood glucose levels tend to drop. Increasing his insulin dosage is not recommended in this case, as it would likely exacerbate his hypoglycemia. Oral corticosteroids are not appropriate for managing hypoglycemia and may in fact exacerbate hypoglycemia, while a continuous glucose monitoring system (CGMS) could help track his glucose levels over time. The immediate solution is to adjust his insulin regimen and monitor his blood sugar more closely. Question 4. A 45-year-old female patient presents with persistent headaches, visual disturbances, and elevated blood pressure (BP) readings of 106 to 90 Fg. She has A family history of hypertension and a sedentary lifestyle. She reports being under significant stress at work and often skipped meals. A review of her lab work reveals elevated cholesterol levels, but her fasting glucose is normal. Following is the most appropriate initial approach for managing this patient's condition. A. Start a thiazide diuretic to manage hypertension. B. Initiate a lifestyle modification program focusing on stress reduction, exercise, and dietary changes. C. Begin an ACE inhibitor and statin therapy immediately. D. Schedule her for an MRI to rule out any structural causes of headaches. Answer B. Initiate a lifestyle modification program focusing on stress reduction, exercise, and dietary changes. Explanation: this patient presents with classic signs of primary hypertension, including elevated BP, headaches, and visual disturbances. Given her risk factors, the first step in management is to initiate lifestyle changes, which include stress reduction techniques, physical activity, and a heart-healthy diet. Diet. These interventions have been shown to reduce BP and cholesterol levels, particularly in individuals who are overweight or sedentary. While pharmacological therapy may eventually be required, the first step is always to try non-pharmacologic interventions, especially since her blood glucose is normal. Starting a diuretic or ACE inhibitor without lifestyle modifications would be premature. MRI is not indicated at this stage, as her symptoms are more likely related to hypertension. Question 5. A 63-year-old male with a history of type 2 diabetes, hypertension, and hyperlipidemia presents with severe chest pain radiating to his left arm. He appears anxious and diaphoretic. The IC shows elevation in the anterior leads. Given these findings, what is the most appropriate first step in the management of this patient? A. Administer nitroglycerin and morphine to manage pain. B. Perform immediate coronary angiography to assess for blockage. C. Start aspirin therapy and prepare for thrombolysis. D. Administer a beta blocker and wait for further diagnostic testing. Answer C. Start aspirin therapy and prepare for thrombolysis. Explanation: this patient is presenting with signs and symptoms of an acute myocardial infarction, including chest pain, radiation to the left arm, diaphoresis, and elevation on ECG. The most appropriate first step in managing ischemic and elevation myocardial infarction is to administer aspirin to prevent further clot formation and prepare for thrombolysis if therapy is not available immediately. Nitroglycerin may be used for pain management, but it should be used cautiously in patients with low blood pressure or certain contraindications. Morphine is also used for pain relief but should not delay primary therapy. Beta blockers should be avoided initially in patients with suspected MI unless there are no contraindications. Immediate coronary angiography is typically performed once the patient is stabilized and thrombolysis therapy is not available. Question 6. A 34-year-old female presents with a complaint of excessive thirst, frequent urination, and unexplained weight loss. She has a family history of type 1 diabetes, and her fasting blood glucose level is 245 mg. Urinalysis reveals ketones, and her HbAC is 9.8%. Given her presentation, what is the most likely diagnosis and what is the most appropriate first step in management? A. Type 1 diabetes mellitus. Initiate insulin therapy immediately. B. Type 2 diabetes mellitus. Start oral hypoglycemic agents. C. Diabetic ketoacidosis DKA. Initiate fluid resuscitation and insulin therapy. D. Hyperosmolar hypoglycemic state. HS astyraminoids and insulin. Answer A. Type 1 diabetes mellitus. Initiate insulin therapy immediately. Explanation: this patient presents with classic symptoms of diabetes mellitus, including polyuria, polydipsia, and weight loss. The elevated fasting blood glucose level of 245 mdl combined with ketones in the urine and a high HbAC is highly indicative of type 1 diabetes mellitus (TDM), which is characterized by autoimmune destruction of pancreatic beta cells and absolute insulin deficiency. Immediate initiation of insulin therapy is crucial for managing TDM and preventing complications such as diabetic ketoacidosis (DKA). Although DKA may also be a consideration due to the presence of ketones, the diagnosis of TDM takes precedence. Type 2 diabetes mellitus typically presents with a more gradual onset and is usually managed. Oral hypoglycemic agents, hyperosmolar hypoglycemic state. HS typically occurs in older adults with type 2 diabetes, not in younger patients with the classic signs of type 1 diabetes. Question 7, scenario-based. Mrs. Garcia, a 58-year-old woman with a history of depression, presents with increasing feelings of sadness, hopelessness, and fatigue over the past 2 weeks. She reports difficulty sleeping, a lack of appetite, and an inability to find joy in activities she once enjoyed. She denies any thoughts of self-harm or harming others. After assessing her symptoms, you determine that she is experiencing a major depressive episode. Given her clinical presentation, what is the most appropriate next step in her management? A. Prescribe an selective serotonin reuptake inhibitor and schedule a follow-up in 2 weeks. B. Refer for inpatient psychiatric care immediately. C. Recommend psychotherapy only and avoid pharmacotherapy at this stage. D. Prescribe a benzodiazepine to manage her anxiety symptoms. Answer A. Prescribe an selective serotonin reuptake inhibitor and schedule a follow-up in 2 weeks. Explanation: Mrs. Garcia's presentation is consistent with a major depressive episode, including symptoms of sadness, loss of interest, sleep disturbance, and appetite changes. The first-line treatment for major depressive disorder, MDD, typically involves a combination of psychotherapy and pharmacotherapy, particularly within a selective serotonin reuptake inhibitor like sertraline or fluoxetine. SRIs are well tolerated, and they work by increasing serotonin levels in the brain, which can help improve mood and reduce symptoms of depression. In this case, inpatient psychiatric care is not indicated since the patient is not suicidal or exhibiting dangerous behaviors. Benzodiazepines are not appropriate for long-term management of depression and should not be used as first-line therapy due to their potential for dependence. Psychotherapy is an important component of treatment, but pharmacotherapy is typically indicated for moderate to severe depression, as in this case. Question 8. A 50-year-old male patient with a history of well-controlled hypertension presents to the clinic with complaints of persistent shortness of breath, fatigue, and leg swelling. His EP is 138/88 heart rate is 92 bpm, and his weight has increased by 5 kilograms in the past 2 weeks. His physical exam reveals bilateral lower extremity edema and an elevated jugular venous pressure, JVP. Given these findings, which of the following is the most likely diagnosis? A. Pulmonary embolism. B. Chronic obstructive pulmonary disease COPD exacerbation. C. Acute myocardial infarction. D. Congestive heart failure. Answer: D. Congestive heart failure. Explanation: this patient is presenting with signs of congestive heart failure, CHF, including shortness of breath, fatigue, lower extremity edema, and an elevated jugular venous pressure, JVP. The weight gain over the past 2 weeks suggests fluid retention, which is a hallmark of CHF. While pulmonary embolism could cause shortness of breath, it is unlikely to cause leg swelling or elevated JVP. COPD exacerbation typically presents with increased cough and sputum production, not peripheral edema. Acute myocardial infarction may also cause shortness of breath and fatigue, but the patient lacks the classic symptoms of chest pain or segment changes on an ECG. CHF is the most likely diagnosis, and the next steps would involve further workup, such as an echocardiogram, to assess left ventricular function. Question 9. A 72-year-old female with a history of osteoporosis and osteoarthritis presents with back pain after lifting a heavy object. On examination, she has tenderness to palpation over the lumbar spine and a mild reduction in height. X-rays reveal vertebral compression fractures at an L. What is the most appropriate management for this patient? A. Start narcotic pain medications and encourage bed rest. B. Prescribe calcium and vitamin D supplements to support bone healing. C. Initiate bisphosphonate therapy and recommend physical therapy for strengthening. D. Schedule the patient for a back surgery consult immediately. Answer: C. Initiate bisphosphonate therapy and recommend physical therapy for strengthening. Explanation: this patient presents with back pain and vertebral compression fractures, which are common complications of osteoporosis. The most appropriate treatment involves bisphosphonates, which help to reduce bone resorption and prevent further fractures. In addition, physical therapy to strengthen the muscles around the spine and improve posture can help reduce and prevent further injury. Narcotic pain medications should be avoided in elderly patients due to the risk of dependence and side effects such as constipation. Calcium and vitamin D are important for bone health, but they are not sufficient for fracture healing or osteoporosis management alone. Surgery is not typically indicated for vertebral compression fractures unless there is nerve involvement or severe disability. Question 10. A 40-year-old male presents with acute onset of severe right lower quadrant abdominal pain, nausea, and vomiting. His vital signs are within normal limits, but he has tenderness to palpation in the right lower abdomen and his white blood cell count is elevated. Aiken reveals an enlarged, inflamed appendix. What is the most appropriate next step in managing this patient? A. Start intravenous antibiotics and schedule for an appendectomy. B. Perform a laparotomy for exploration of the abdomen. C. Start intravenous fluids and observe for 24 hours before proceeding to surgery. D. Prescribe oral antibiotics and schedule an outpatient follow-up. Answer: A. Start intravenous antibiotics and schedule for an appendectomy. Explanation: this patient presents with classic signs of acute appendicitis, including severe right lower quadrant pain, nausea, vomiting, and elevated white blood cell count. The best initial management for appendicitis includes starting intravenous antibiotics to cover potential infection and scheduling the patient for an appendectomy. Surgical removal of the appendix is definitive treatment for appendicitis, and the use of intravenous antibiotics helps reduce the risk of infection during and after the procedure. Antibiotics are given preoperatively to help manage any possible peritoneal contamination. Laparotomy or more invasive exploratory procedures are not required unless there is suspicion of complications such as perforation or abscess formation. Observing the patient for 24 hours is not appropriate in the setting of acute appendicitis, as it can lead to complications, including perforation. Oral antibiotics alone would not be adequate treatment for this condition, as surgery is necessary for resolution. Question 11. A 28-year-old female presents with the 3-day history of fever, chills, cough, and pleuritic chest pain. She is a smoker and has no significant past medical history. Physical exam reveals decreased breath sounds and dullness to percussion on the left side. Chest X-ray shows a left-sided pleural effusion with a consolidated area. What is the most likely diagnosis and what is the next step in management? A. Community-acquired pneumonia. Initiate antibiotics and observe. B. Pulmonary embolism. Administer anticoagulation therapy and perform angiogram. C. Tuberculosis. Start appropriate antitubercular therapy. D. Parapneumonic effusion PERMA. Perform thoracentesis and initiate antibiotics. Answer: D. Parapneumonic effusion PERMA. Perform thoracentesis and initiate antibiotics. Explanation: this patient presents with symptoms and radiographic findings suggestive of a parapneumonic effusion or empoma. The left-sided pleural effusion seen on the chest X-ray, along with pleuritic chest pain, is indicative of a complication of pneumonia. In such cases, the next step in management is typically thoracentesis, which can both diagnose the cause, e.g. infection, malignancy, and relieve symptoms. Empyema, characterized by infection within the pleural space, requires immediate antibiotic therapy, often with broad spectrum coverage initially. Community-acquired pneumonia, CAP, could be the underlying cause, but the presence of a pleural effusion makes the diagnosis more likely to be parapneumonic effusion or empyema. Pulmonary embolism, P, could cause pleuritic pain and dyspnea, but it is less likely to cause a pleural effusion or consolidation on imaging. Tuberculosis is a potential consideration, but this patient does not have the chronic symptoms typically associated with TB, and the imaging findings are more consistent with infection-related effusion. Question 12. A 65-year-old male with a history of atrial fibrillation presents with a complaint of sudden onset right-sided weakness and difficulty speaking. He is alert but has difficulty forming words. His blood pressure is 100 to 100 mmHg and his heart rate is irregularly irregular. A non-contrast HET CT shows no acute hemorrhage. What is the most appropriate next step in this patient's management? A. Administer thrombolytics (EPA) for acute ischemic stroke. B. Initiate aspirin and statins for secondary prevention of stroke. C. Perform carotid ultrasound to assess stenosis. D. Start anticoagulation therapy with warfarin or DOAC, direct oral anticoagulant. Answer: A. Administer thrombolytics (TPA) for acute ischemic stroke. Explanation: this patient presents with symptoms of a potential acute ischemic stroke evidenced by sudden onset right-sided weakness and aphasia, difficulty speaking. Given the absence of hemorrhage on the head CT, thrombolytics EPA are appropriate for patients who present within a 3-4.5 hour window from symptom onset. Immediate treatment with TPA can help dissolve the clot and improve outcomes in cases of ischemic stroke, although anticoagulation therapy with warfarin or a DOAC is important in patients with atrial fibrillation to prevent future strokes. This would not be appropriate in the acute phase of a stroke. Aspirin and statins are part of stroke prevention but are not indicated immediately in an acute stroke. Carotid ultrasound can be helpful in assessing the cause of stroke but is not an urgent next step in the acute phase of ischemic stroke management. Question 13. A 25-year-old woman presents with a 2-week history of fatigue, unexplained weight loss, and a low-grade fever. She also reports a painless, swollen lymph node in her neck. She is sexually active with multiple partners. On examination, she has generalized lymphadenopathy and a non-tender enlarged spleen. Her HIV test is positive. What is the next step in her management? A. Start antiretroviral therapy, ART, immediately. B. Initiate empiric antibiotics for suspected bacterial infection. C. Schedule a follow-up visit in 6 weeks for reassessment. D. Order a EUNT HIV viral load to assess the stage of infection. Answer: D. Order a HIV viral load to assess the stage of infection. Explanation: this patient presents with symptoms that suggest acute HIV infection, fever, weight loss, lymphadenopathy, and splenomegaly. The next step is to assess the stage of HIV infection by measuring the CD count and HIV viral load. These tests provide critical information regarding the progression of the disease and guide the initiation. Antiretroviral therapy, ART. While ART is important, it is essential to assess the HIV viral load and CD count to determine the appropriate timing for starting ART. Empiric antibiotics are not indicated at this time since the patient's symptoms are likely related to HIV. A follow-up in 6 weeks is too delayed. Early intervention with appropriate testing and initiation of ART are critical. Question 14. A 55-year-old man presents with a complaint of sudden onset severe abdominal pain in the epigastric region which radiates to his back. He has a history of chronic alcohol use and has been drinking heavily over the past week. His vital signs show a heart rate of 110 bpm and a blood pressure of 90/60 mmHg. Amylase and lipase levels are elevated. What is the most likely diagnosis and what is the next step in management? A. Acute pancreatitis, initiate Romanuids and fasting. B. Peptic ulcer disease, a prescribed proton pump inhibitors, PPIS and H. pylori therapy. C. Cholecystitis, order an ultrasound and tyromin antibiotics. D. Gastritis, initiate antacids and H blockers. Answer: A. Acute pancreatitis, initiate Romanuids and fasting. Explanation: this patient presents with classic symptoms of acute pancreatitis, including sudden onset severe epigastric pain radiating to the back, along with elevated amylase and lipase levels. The history of chronic alcohol use is a common risk factor for acute pancreatitis. The most appropriate initial management involves supportive care with intravenous fluid, stress dehydration and hypotension, along with fasting (NPO) to allow the pancreas to rest and reduce inflammation. Peptic ulcer disease could present with abdominal pain, but would not typically cause elevated amylase and lipase levels. Cholecystitis presents with right upper quadrant pain and fever, not epigastric pain, and would require an ultrasound to confirm the diagnosis. Gastritis can cause abdominal discomfort, but would not typically with severe pain and elevated enzyme levels. Question 15. A 40-year-old male presents with a 2-day history of chest pain that is sharp and worsens with deep breathing. He denies any prior heart disease and has no significant medical history. On physical examination, his temperature is 101 nec, heart rate is 110 bpm, and respiratory rate is 22. His lungs are clear to auscultation, and his heart exam is unremarkable. He has tenderness over the left side of his chest. An X shows no acute changes. What is the most likely diagnosis and what is the next best step in management? A. Acute pericarditis. Start NSAIDs and colchicine. B. Acute myocardial infarction. Administer aspirin and nitroglycerin. C. Pulmonary embolism. Perform CT pulmonary angiogram. D. Costochondritis. Advise supportive care and reassurance. Answer: A. Acute pericarditis. Start NSAIDs and colchicine. Explanation: this patient presents with sharp chest pain that worsens with deep breathing and pleuritic characteristics, which is highly suggestive of acute pericarditis. The absence of significant heart disease and normal ECG, along with localized chest tenderness, makes myocardial infarction and pulmonary embolism less likely. The best treatment for acute pericarditis involves anti-inflammatory agents such as NSAIDs and colchicine to reduce inflammation and alleviate pain. Costochondritis could present with chest pain, but typically lacks systemic symptoms such as fever and elevated heart rate. Pulmonary embolism is a possibility but would likely present with more significant respiratory symptoms and hypoxia. Question 16. A 70-year-old female with a history of osteoarthritis presents with new onset confusion, difficulty speaking, and right-sided weakness. Her daughter notes that she has had some difficulty walking over the past few days and she is now unable to stand on her own. On examination, her speech is slurred and she has a positive Babinski sign on the right. What is the most likely diagnosis and what should be done next? A. Acute ischemic stroke. Administer EPA and perform a non-contrast head CT. B. Transient ischemic attack TIA. Initiate antiplatelet therapy and schedule a follow-up in 1 week. C. Brain tumor. Order a MRI. D. Acute viral encephalitis. Obtain a lumbar puncture for analysis. Answer A. Acute ischemic stroke. Administer EPA and perform a non-contrast head CT. Explanation. This patient presents with new onset neurological deficits, including slurred speech, weakness, and a positive Babinski sign, which are concerning for an acute ischemic stroke. The most appropriate next step is to perform a non-contrast head CT to rule out hemorrhagic stroke and then administer PA if within the time window. Thrombolysis. A tear presents with similar symptoms but resolves within 24 hours and does not cause permanent deficits. Brain tumors can present with neurological changes but would typically have a more gradual onset of symptoms. Viral encephalitis usually presents with altered mental status, fever, and other signs of infection which are not present in this patient. Question 17. A 60-year-old male with a history of smoking presents with a persistent cough, hemoptysis, and weight loss over the past 2 months. He has a 30-pack-year smoking history and denies any recent illnesses. On physical examination, he is cachectic and has decreased breath sounds in the left lower lung field. A chest X-ray reveals a mass in the left lower lung and possible hilar lymphadenopathy. What is the most likely diagnosis and what is the next best step in management? A. Small cell lung cancer. Initiate chemotherapy. B. Non-small cell lung cancer. Refer for biopsy and staging. C. Pulmonary tuberculosis. Start anti-tubercular therapy. D. Community-acquired pneumonia. Initiate antibiotics. Answer B. Non-small cell lung cancer. Refer for biopsy and staging. Explanation. The patient's symptoms, persistent cough, weight loss, hemoptysis, and history of smoking, are highly suggestive of lung cancer, most likely non-small cell lung cancer (SLC), which is the most common type in smokers. The next step is to refer the patient for biopsy and staging to confirm the diagnosis and determine the appropriate treatment. Small cell lung is another possibility, but it tends to present more aggressively and is associated with more systemic symptoms. Pulmonary tuberculosis is consideration in the differential, especially in cases with weight loss and cough, but the chest X-ray findings of mass and hilar lymphadenopathy are more consistent with cancer. Community-acquired pneumonia typically presents with fever, cough, and consolidation on chest X-ray, which is not the case here. Question 18. A 45-year-old male presents with a 3-month history of increasing fatigue and intentional weight loss and generalized itching. He has no significant medical history and is not on any medications. On examination, his skin is jaundiced and his liver is enlarged and tender to palpation. Laboratory tests reveal an elevated bilirubin level and positive anti-smooth muscle antibodies. What is the most likely diagnosis and what is the next step in management? A. Hepatitis C. Initiate antiviral therapy. B. Primary biliary cirrhosis. Refer to a hepatologist for liver biopsy and management. C. Alcoholic liver disease. Advise alcohol cessation and initiate supportive care. D. Wilson's disease. Start chelation therapy with penicillamine. Answer B. Primary biliary cirrhosis. Refer to a hepatologist for liver biopsy and management. Explanation. This patient presents with signs and symptoms suggestive of primary biliary cirrhosis (PBC), including jaundice, fatigue, itching, and elevated bilirubin levels. The positive and anti-smooth muscle antibodies are also characteristic of PBC. The next step in management is to refer the patient to a hepatologist. Further evaluation and potential liver biopsy to confirm the diagnosis. Hepatitis C typically presents with chronic liver disease but would not cause this constellation of symptoms or a positive anti-smooth muscle antibody. Alcoholic liver disease is more likely in patients with a history of heavy drinking, which is absent in this case. Wilson's disease typically presents in younger patients with neurological symptoms and abnormal copper metabolism, which is not seen here. Question 19. A 25-year-old male presents with a 2-week history of fever, night sweats, and a productive cough with greenish sputum. He has no significant past medical history and does not smoke. On physical examination, he is febrile with decreased breath sounds and dullness to percussion on the right side. A chest X-ray shows consolidation in the right lower lobe with a pleural effusion. What is the most likely diagnosis and what is the next step in management? A. Community-acquired pneumonia with parapneumonic effusion. Start antibiotics and perform thoracentesis. B. Pulmonary embolism with infarction. Perform a pulmonary angiogram. C. Tuberculosis. Begin anti-tubercular therapy and isolate the patient. D. Bronchitis with post-bronchial effusion. Initiate bronchodilators and supportive care. Answer: A. Community-acquired pneumonia with parapneumonic effusion. Start antibiotics and perform thoracentesis. Explanation: This patient's presentation is most consistent with community-acquired pneumonia complicated by parapneumonic effusion. The productive cough, fever, and chest X-ray findings of consolidation with pleural effusion are hallmark signs of pneumonia, with an associated pleural fluid collection. The next step is initiate broad-spectrum antibiotics and perform thoracentesis to assess the nature of the pleural fluid. Pulmonary embolism could present with pleuritic chest pain and pleural effusion, but this patient's cough, fever, and consolidation point more to pneumonia. Tuberculosis is consideration, but the acute nature of the symptoms and the absence of other risk factors make it less likely. Bronchitis typically does not cause significant consolidation. Pleural effusion. Question 20. A 72-year-old female with a history of diabetes mellitus presents with increasing shortness of breath over the past few weeks. She has a non-productive cough, fatigue, and bilateral lower extremity edema. On physical exam, her blood pressure is 169 Hg and her heart rate is 88 bpm. Pulmonary auscultation reveals bilateral crackles at the lung bases. The chest X-ray shows cardiomegaly and pulmonary edema. What is the most likely diagnosis and what is the next best step in management? A. Congestive heart failure. Initiate diuretics and ACE inhibitors. B. Chronic obstructive pulmonary disease. Start bronchodilators. C. Acute respiratory distress syndrome. ARDS. Intubate and provide mechanical ventilation. D. Interstitial lung disease. Refer for pulmonary function tests. Answer: A. Congestive heart failure. Initiate diuretics and ACE inhibitors. Explanation: This patient's symptoms and signs: shortness of breath, bilateral lower extremity edema, and bilateral crackles on auscultation are consistent with congestive heart failure (CHF). The chest X-ray showing cardiomegaly and pulmonary edema further supports this diagnosis. The next step in management is to initiate diuretics to reduce fluid overload and ACE inhibitors to manage blood pressure and improve heart function. COP could cause respiratory symptoms but would not explain the edema and chest X-ray findings of cardiomegaly and pulmonary edema. ARDS typically presents acutely with severe hypoxia and requires mechanical ventilation. Interstitial lung disease can cause respiratory symptoms but would usually present with restrictive lung patterns on pulmonary function tests, which are not indicated initially in this scenario. Question 21. A 34-year-old woman presents with a 6-month history of fatigue, hair loss, and sensitivity to cold. On physical examination, her skin appears dry and her reflexes are sluggish. Laboratory results show an elevated TSH and a low free. What is the most likely diagnosis and what is the next step in management? A. Hypothyroidism due to Hashimoto's thyroiditis. Start levothyroxine therapy. B. Hypothyroidism due to Graves' disease. Refer for radioactive iodine treatment. C. Adrenal insufficiency. Initiate hydrocortisone therapy. D. Iron deficiency anemia. Prescribe iron supplementation. Answer: A. Hypothyroidism due to Hashimoto's thyroiditis. Start levothyroxine therapy. Explanation: This patient's symptoms: fatigue, hair loss, sensitivity to cold, and dry skin are consistent with hypothyroidism, particularly when coupled with laboratory results showing an elevated TH and low free T. Hashimoto's thyroiditis is the most common cause of primary hypothyroidism. The next step in management is to start levothyroxine therapy, which will replace the deficient thyroid hormone. Hypothyroidism would present with symptoms such as weight loss, heat intolerance, and tachycardia, which are not present in this case. Adrenal insufficiency can present with fatigue, but would also cause electrolyte imbalances and low blood pressure, which are not seen here. Iron deficiency anemia can cause fatigue, but would not explain the other symptoms, and it would typically present with low hemoglobin and ferritin levels. Question 22. A 50-year-old woman presents with a 3-month history of progressively worsening headache, nausea, and vomiting. She has noticed double vision and difficulty walking. Her neurological exam reveals papilledema and ataxia. An MRI of the brain reveals a mass in the posterior fossa with surrounding edema. What is the most likely diagnosis and what is the next step in management? A. Brain metastases. Initiate radiation therapy. B. Glioblastoma. Refer for surgical resection. C. Primary brain tumor medulloblastoma. Refer for neurosurgical consultation and biopsy. D. Acute hydrocephalus. Insert a ventricular shunt. Answer: C. Primary brain tumor medulloblastoma. Refer for neurosurgical consultation and biopsy. Explanation: this patient presents with headache, nausea, vomiting, and ataxia, which are signs of increased intracranial pressure. Papilledema and double vision further suggest a neurological etiology, and the MRI findings of a mass in the posterior fossa are characteristic of medulloblastoma, a primary brain tumor typically located cerebellum. The next step is a neurosurgical consultation and biopsy to confirm the diagnosis and plan for treatment. Brain metastases is less likely given the patient's age and the location of the mass. Glioblastoma is a highly aggressive tumor that more commonly affects the cerebral hemispheres. Acute hydrocephalus could be a complication but is secondary to the mass rather than the primary cause. Question 23. A 42-year-old male with a history of alcohol use disorder presents with confusion, ataxia, and ophthalmoplegia. His examination reveals nystagmus and bilateral ptosis. He is unable to walk unassisted and shows signs of ataxia. Given his history of alcohol use, what is the most likely diagnosis and what is the next step in management? A. Wernicke-Korsakoff syndrome. Administer thiamine supplementation. B. Acute alcohol intoxication. Provide supportive care. C. Cerebellar stroke. Perform a angiogram. D. Guillain-Barré syndrome. Initiate intravenous immunoglobulin. Answer: A. Wernicke-Korsakoff syndrome. Administer thiamine supplementation. Explanation: is patient presents with confusion, ataxia, ophthalmoplegia, and nystagmus, which are suggestive of Wernicke-Korsakoff syndrome, a condition associated with thiamine deficiency due to chronic alcohol use. The next step in management is to administer thiamine supplementation, which can reverse acute symptoms. Acute alcohol intoxication typically causes depressed level of consciousness but would not explain the neurological signs of ataxia and ophthalmoplegia. Cerebellar stroke could cause ataxia, but it would not explain the nystagmus and confusion in this clinical context. Guillain-Barré syndrome is possibility but typically presents with progressive muscle weakness rather than ataxia and cranial nerve involvement. Question 24. A 60-year-old female with a history of hypertension presents with sudden onset severe headache, nausea, and vomiting. She describes the headache as the worst headache of my life. On examination, she has neck stiffness and photophobia. A K of the head shows no evidence of hemorrhage. What is the most likely diagnosis and what is the next step in management? A. Subarachnoid hemorrhage. Perform a lumbar puncture to check for blood in the cerebrospinal fluid. B. Meningitis. Begin empirical antibiotics and lumbar puncture. C. Cluster headache. Provide oxygen therapy. D. Migraine headache. Initiate triptan therapy. Answer: A. Subarachnoid hemorrhage. Perform a lumbar puncture to check for blood in the cerebrospinal fluid. Explanation: the patient's sudden onset severe headache, described as the worst headache of my life, along with neck stiffness and photophobia, is highly suggestive of a subarachnoid hemorrhage, which often presents with a thunderclap headache. While the CT scan of the head does not show hemorrhage, the next step in management is to perform a puncture to check for blood in the cerebrospinal fluid (CSF), which can confirm the diagnosis. A meningitis present similarly, but typically includes fever and other signs of systemic infection, which are absent here. Cluster headaches are usually unilateral and associated with autonomic symptoms such as lacrimation or rhinorrhea, which are not present. Migraines do not typically present with sudden onset severe headache or neck stiffness. Question 25. A 32-year-old pregnant woman at 28 weeks gestation presents with a 2-day history of swelling in her feet and hands. She also complains of headaches and blurred vision. On examination, her blood pressure is 160/100 Thg and she has 3 proteinuria. What is the most likely diagnosis and what is the next best step in management? A. Preeclampsia. Initiate antihypertensive therapy and monitor closely. B. Gestational hypertension. Recommend rest and frequent monitoring. C. Chronic hypertension. Initiate antihypertensive therapy. D. Acute renal failure. Order renal ultrasound and start dialysis. Answer A. Preeclampsia. Initiate antihypertensive therapy and monitor closely. Explanation: this patient's presentation with hypertension, proteinuria, and edema in the setting of pregnancy is most consistent with preeclampsia. Preeclampsia is diagnosed by the new-onset hypertension and proteinuria after 20 weeks of gestation and can be complicated by severe features such as headache and blurred vision. The next step in management is initiate antihypertensive therapy and closely monitor for signs of progression to severe preeclampsia or eclampsia. Gestational hypertension presents with elevated blood pressure but does not include proteinuria or severe features like headaches and visual changes. Chronic hypertension would have been diagnosed prior to pregnancy and is not likely in this case. Acute renal failure would present with worsening renal function, which is not indicated. Question 26. A 70-year-old male presents with progressive memory loss, difficulty concentrating, and personality changes over the past 6 months. His family reports that he is no longer able to manage his finances or remember appointments. On examination, he shows signs of disorientation and poor judgment. What is the most likely diagnosis and what is the next step in management? A. Alzheimer's disease. Refer for neuropsychological testing and cognitive therapy. B. Vascular dementia. Initiate antihypertensive therapy and antiplatelet therapy. C. Depression. Start selective serotonin reuptake inhibitors (SRIs). D. Frontotemporal dementia. Refer for genetic counseling and family support. Answer A. Alzheimer's disease. Refer for neuropsychological testing and cognitive therapy. Explanation: the patient's progressive memory loss, difficulty concentrating, and personality changes are characteristic of Alzheimer's disease, the most common form of dementia. The next step is to refer for neuropsychological testing to assess the degree of cognitive impairment and to explore non-pharmacological treatments, including cognitive therapy. Vascular dementia can present with cognitive decline, but typically follows stepwise progression related to vascular events such as strokes, which is not described in this case. Depression can cause cognitive symptoms, but these typically improve with mood treatment and the patient lacks history of depressed mood. Frontotemporal dementia is characterized by early personality and behavioral changes, but is less likely given the predominant memory symptoms. Question 27. A 55-year-old woman with a history of obesity presents with new-onset dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. She has bilateral lower extremity edema and a displaced apical impulse. A chest X-ray shows cardiomegaly, and an echocardiogram reveals a reduced ejection fraction. What is the most likely diagnosis and what is the next best step in management? A. Heart failure with reduced ejection fraction. Initiate ACE inhibitors, diuretics, and beta blockers. B. Pulmonary embolism. Perform a pulmonary angiogram. C. Chronic obstructive pulmonary disease. COPD. Initiate bronchodilators and steroids. D. Myocardial infarction. Administer aspirin and nitroglycerin. Answer A. Heart failure with reduced ejection fraction. Initiate ACE inhibitors, diuretics, and beta blockers. Explanation: this patient presents with signs and symptoms of heart failure including dyspnea, orthopnea, paroxysmal nocturnal dyspnea, bilateral edema, and cardiomegaly on chest X-ray. The reduced ejection fraction on echocardiogram confirms heart failure with reduced ejection fraction (HFrEF). The next step in management is initiate appropriate pharmacologic therapy, including ACE inhibitors, diuretics to manage fluid overload, and beta blockers to improve cardiac function and prevent further deterioration. Pulmonary embolism could present with shortness of breath but would not explain the systemic symptoms or the cardiomegaly seen on X-ray. COPD can cause shortness of breath but is not typically associated with cardiomegaly or reduced ejection fraction. Myocardial infarction would present with acute chest pain and ECG changes, which are not seen here. Question 28. A 45-year-old male with a history of type 2 diabetes mellitus presents with blurry vision, difficulty reading, and poor night vision. He has noticed a gradual worsening of these symptoms over the past few months. On examination, his pupils are dilated and sluggish to react to light. What is the most likely diagnosis and what is the next step in management? A. Diabetic retinopathy. Refer to an ophthalmologist for retinal examination. B. Cataracts. Refer for surgical consultation. C. Glaucoma. Check intraocular pressure and refer for glaucoma surgery. D. Macular degeneration. Initiate anti-VEGF therapy. Answer A. Diabetic retinopathy. Refer to an ophthalmologist for retinal examination. Explanation: this patient's blurry vision, difficulty reading, and poor night vision are common symptoms of diabetic retinopathy, complication of diabetes mellitus that affects the retina. The next step in management is to refer the patient to an ophthalmologist for thorough retinal examination to assess the degree of retinopathy and determine if any intervention needed. Cataracts typically cause cloudy vision and difficulty with glare, but are less likely to cause poor night vision alone. Glaucoma would present with increased intraocular pressure and potential visual field loss. Macular degeneration is more common in older adults and causes central vision loss, not the symptoms described here. Question 29. A 30-year-old female with a history of lupus presents with new-onset shortness of breath, pruritic chest pain, and hemoptysis. On examination, her blood pressure is 138 mmHg and her heart rate is 100 TEM. A pulmonary angiogram reveals a large saddle embolus in the pulmonary arteries. What is the most likely diagnosis and what is the next step in management? A. Pulmonary embolism. Initiate anticoagulation therapy. B. Systemic lupus erythematosus flare. Increase corticosteroid dosage. C. Pneumonia. Start empirical antibiotics. D. Acute myocardial infarction. Perform coronary angiography. Answer A. Pulmonary embolism. Initiate anticoagulation therapy. Explanation: this patient's symptoms of shortness of breath, pruritic chest pain, and hemoptysis, along with CT pulmonary angiogram revealing large saddle pulmonary embolus, confirm the diagnosis of pulmonary embolism P. The next step in management is to initiate anticoagulation therapy, as P is a life-threatening condition that can lead to right heart failure and, if not treated promptly, systemic lupus erythematosus (SLE) flare could cause pruritic chest pain, but would not explain the saddle embolus seen on imaging. Pneumonia typically presents with fever and cough and would not cause saddle embolus. Acute myocardial infarction usually presents with chest pain, but would not cause pruritic pain or hemoptysis. Question 30. A 55-year-old male with a history of chronic smoking presents with a persistent cough, weight loss, and hemoptysis. On examination, he has decreased breath sounds in the right upper lobe and a palpable supraclavicular lymph node. The chest X-ray reveals a spiculated mass in the right lung. What is the most likely diagnosis and what is the next step in management? A. Lung cancer. Refer for biopsy and staging studies. B. Tuberculosis. Initiate empirical anti-tuberculosis therapy. C. Pneumonia. Start empirical antibiotics. D. Pulmonary embolism. Perform a pulmonary angiogram. Answer A. Lung cancer. Refer for biopsy and staging studies. Explanation: this patient's history of smoking, persistent cough, weight loss, hemoptysis, and spiculated mass on chest X-ray are all concerning for lung cancer, which is commonly associated with these symptoms. The next step in management is to refer the patient for biopsy and staging studies to confirm the diagnosis and determine the extent of disease. Tuberculosis (TB), weight loss and cough, but is less likely in this patient without prior exposure history and the presence of mass. Pneumonia typically presents with fever, cough, and sputum production and would not explain the spiculated mass seen on X-ray. Pulmonary embolism typically causes sudden onset chest pain and shortness of breath, not the symptoms described here.